Greetings. Today, Kyle and I were going to talk about transposition of the great arteries. Now, this is a congenital heart defect. It happens because of abnormal development of the fetal heart during the first 8 weeks of gestation. So that's first 8 weeks is when the heart forms, and that's when we start seeing the abnormality. And basically what happens, the large vessels that transport blood from the heart to the lungs and to the body, they're connected improperly. They're swapped. So that makes it so it's opposite to normal heart anatomy. The aorta ends up being connected to the right ventricle, and the pulmonary artery ends up being connected to the left ventricle. So this means that most of the blood bypasses the lungs and the left side of the heart entirely. So this brings obvious problems with these vessels being swapped. Basically, instead of having the pulmonary artery taking it to the lungs and oxygenating blood and then rerouting it back to the body, it's all switched. So the point where you should have blood being oxygenated delivered to the body, it isn't happening. We're bypassing the lungs. The pulmonary artery goes straight to the left ventricle, so it doesn't even allow for the oxygenation to occur. So shunt. The question is it a shunt? It's not a shunt. It's transposition of the arteries. So the arteries they're transposed. They're in the wrong place, connected improperly. But it's not technically a shunt. We hear about right to left shunt, left to right shunt. Where is the blood shunting away? But the problem here is the arteries the vessels are in the wrong place, and that causes a whole host of problems. Now, in our research, what we were looking up, we found out that many times when you have transposition of the arteries, you do get other problems, other defects associated with it. But as far as shunting goes, left to right shunt, we're not calling it a shunt.
Many of the signs and symptoms that we see quickly after birth will be what we typically relate to hypoxemia, such as tachypnea, tachycardia, and cyanosis. This happens because the body is not receiving well-oxygenated blood, as Armando explained earlier. Since deoxygenated blood is barely mixing with oxygenated blood through the now closing foramen ovale and ductus arteriosus, something has to be done to keep the newborn oxygenated. We also found that transposition of the great arteries usually comes with a heart defect called ventricular septal defect, which is where there's a hole between the two ventricles that allows for mixing of blood, much like the foramen ovale. So there are a couple of quick treatments we can do and need to do to allow for mixture of blood for both sides of the heart, especially if there is no ventricular septal defect. So they usually do these treatments, which we'll talk about in the next couple of slides, to stabilize the newborn before being able to do surgery to fully resolve the underlying issue, which is the major arteries being swapped. So luckily, transposition of the great arteries can be diagnosed before birth, so treatment can begin right away when the infant is born. As I was saying a moment ago about treatments that work quickly to stabilize the newborn, one of those is called prostaglandin. Prostaglandin is a drug and is administered through IV. What it does is it stops the ductus arteriosus from closing to allow for mixture of oxygenated blood from the pulmonary artery to the aorta that has deoxygenated blood. So remember that ductus arteriosus was a vessel that connects the pulmonary artery and the aorta. So with this remaining open, we as the respiratory therapist would need to make sure that the blood that's flowing through the lungs and the left side of the heart is extremely oxygenated to provide more oxygen when it gets mixed through the ductus arteriosus.
Okay, so continuing on with the management and treatment of this defect, transposition of the great arteries. So something that we want to do first, obviously Kyle already touched on it a little bit, but we want to make sure that we oxygenate and ventilate. A lot of times we do end up intubating most of the time these babies because of their heart defect. We want to make sure they're well oxygenated. So as we're buying a little bit more time as we're fixing the problem with the heart. So something else we do is called cardiac catheterization. So we actually use this to diagnose and to treat. It's something that's used diagnostically. It's a procedure that we do, and we can kind of tell where the big problem is. And something as far as treating goes, we use this catheterization as well to do a procedure called atrial septostomy. So this is why we do this. We do it to prevent the mixing of oxygenated and deoxygenated blood. There's a special balloon catheter that is used to create an opening in the atrial septum, and then that catheter is guided through the foramen ovale and into the left atrium. So the balloon is then inflated and it's pulled back through the hole into the right atrium, and this basically allows blood to mix between the atria. So this whole process, we do the catheterization, we find out where the problem is, and then we can use this atrial septostomy procedure to inflate this balloon, and we're creating an opening allowing the blood to mix. Now it's a therapy, it's good, it's helpful, but this isn't, eventually we want to lead on to surgery. That's what Kyle's going to talk about in the next slide. This is kind of a temporary fix, to allow for the mixing of blood.
Now we'll talk about the surgery that's done to fix transposition of the great arteries. And it's called an arterial switch, and I want to quickly applaud this surgery and the surgeons that perform it. Because they're saving babies' lives that have this heart defect, and it's a very complicated surgery. And this surgery needs to be performed within the first 2 weeks of life, or other complications will arise. And with the surgery, they swap the arteries back to where they belong to create a normal heart. And it's a more complicated surgery than just that. The coronary arteries are connected very closely to the valve coming out of the heart. And so they have to carefully just cut away just around the coronary arteries and to detach them, and the aorta is just cut above that to have a clean cut away, and then connecting it back to where it goes, they have to cut out those little sections where the coronary arteries connect to, and then connect the aorta and the coronary arteries back to where they belong, and then the same thing with the pulmonary artery. Now, post-surgery is very beneficial for the infant to be on a ventilator. So us, as the respiratory therapists, we will care for the ventilator and assess the lungs to assure they are functioning properly. And we'll also monitor the baby for any distress and cyanosis, which can tell us that something is still wrong. And now, the baby may require further heart surgeries, because like I said before, it is commonly seen with transposition of the great vessels that the infant will also have a ventricular septal defect, which is that hole between the two ventricles. And this can repair itself, but it is common that they have surgery to repair it. And also, we perform the balloon atrial septostomy, which makes the foramen ovale much larger than it normally is. So surgery may also be required to repair that. And so the infants that have these surgeries, they have very normal lives after they've recovered and everything's how it should be, and they have normal hearts. And that is Transposition of the Great Arteries by Armando and Kyle.